Okay. So hello, everyone. So we're going to wait for a couple of seconds to make sure that all attendees are joining. And I can see that it's pouring inside, so it's perfectly fine. And, and thank you all for being here for this recorded Q&A session about the Pain Summit presentation. We have two sets of panelists today from pain assessments, multiple methods, and pain model, pain communication and application. So we are 4 panelists today, and in a couple of seconds, we are going to introduce all of our speakers, and after we're going to have your question. So for the attendees, you're able to ask your question through the Q&A session below. So it's only written question. I'm sorry for that. And then of course, if you cannot attend this session, it will be a recorded Q&A session that you will be able to see on the Academy platform afterwards. And so I can see that maybe we can start the introduction with I'm going just with the organization on my computer. Albinder, maybe you can start.
Thank you. So my name is Professor Harbinder Sandhu. I'm a professor of health psychology at the University of Warwick, Warwick Clinical Trials Unit. A lot of my research is around designing complex behavior change interventions and testing sort of effectiveness within clinical trials and around pain and pain management. So for my presentation, I focused on the clinical application. So when we're looking at communication skills and trying to understand the complexities that we as clinicians face with our patients, but also patients also face when trying to explain or express their challenges of living with pain. So it's very much looking at sort of the clinical side of how we can improve and communication skills. Thank you.
Super, thank you. Ulrike?
Search for microphone button. Yeah. My name is Ulrike Kaiser. I come from Germany, from Dresden, but I work in Lübeck at the University Hospital. I'm a clinical psychologist by training, actually, but for a couple of years, I'm engaged in patient-reported outcome measure development and public health research. My part was to introduce you to the situation of assessing pain and associated factors. And I tried to show you that we need some work, or some work has to be done, which is harmonizing core outcome set measurements and clinical trials for pain treatments. And also I showed you how important it is to consider patient-reported outcome and patient-reported outcome measures, what it is and what kind of challenges we are still facing. And just a key reminder, maybe you remind the word content validity, which is to have a clear patient-reported outcome construct developed by clinicians and patients or people with lived experience, and then developing a sufficient patient-reported outcome measure, which is the next step of generation of measurement development. Thank you.
Thank you, Ulrike. Claire?
Hi, everyone. I'm Claire Ashton-James. I'm an associate professor in pain management at the University of Sydney. I'm a social psychologist by training, and my sort of area of expertise is patient and clinician emotion and patient-clinician communication and social interventions for pain, and how we can start leveraging the social aspects of the biopsychosocial model to improve outcomes in people with pain. So I'm happy to answer your questions.
Super. And of course, Kai.
Hello, everyone. My name is Kai Karotz. I'm freshly now an assistant professor at Maastricht University in the Netherlands. My research thus far focuses on social factors in pain broadly, doing experimental research in that area, specifically social threat. And I think most relevant for this talk was the effect of social threat on pain expression. So my talk was mainly on the theoretical foundations of pain expression and pain assessment, the role of evolutionary psychology in that process, and why we really need a better understanding of social factors in pain, especially when it comes to pain assessment and pain expression.
Super. Thank you all. And as you can see, we have a really nice general topic about pain assessment and bias. And so I'm really looking forward to this discussion. And while we encourage our attendees to ask questions, we also encourage our panelists to ask questions to each other, mostly because it's really, a relevant topic for each other. And one of my first questions would be, what is in your mind a key issue currently in your field? And maybe we can start again with Arvinder.
Yeah, so I think one of the key issues in our field is probably around how we can really develop that therapeutic relationship with the patient, and how we can really explore some of those complexities that we've talked about and incorporate in the biopsychosocial model. A lot of the time, especially with something like chronic pain and not having a long-term condition, it's the stigmatization that comes with that when a patient attends even the first consultation, or it could be the third or fourth or fifth, and how can we use our language to help the patient in their journey, to make them feel a part of the decision making, rather than feeling like, this is, I'm not getting anywhere, and that frustration, which we know that can have a massive impact on their sort of rehabilitation and how they manage their pain. So that's a real key challenge, and I think it's part of my work is also delivering training and facilitation skills in that communication, and that continues to be something that I think still needs research and ways of improving.
Thank you very much. And so we are going to finish the round. Ulrike, how about you?
Yeah, my key challenge in my field, even though I really agree with Harbinder for the relationship between patient and healthcare professional, my key challenge actually is to raise awareness of the situation of patient-reported outcome measures, because most of us still think that we have good instruments, but we do not. And this has much implication for interpretation of clinical study results, for allocation to treatments, for decisions in healthcare systems. And this is something which connects to Harbinder's key challenge. I think we researchers need to understand that the patient is a partner and not something to be investigated, something, in a closer meaning. And to involve patients and public into research, development research questions, developing research protocols. Just not only we clinicians think of research questions, also the people with lived experience have questions for us. And they're sometimes really different, but always interesting and inspiring. So I would like to have a field of research and researchers who involve patients and people with lived experiences in a common way, not just as a nice to have or an add-on, in a common way. So this is my key challenge.
Super, thank you very much. How about you, Claire?
Yeah, I agree with what the panelists have said so far. I guess in addition, I would add that a key challenge in training, in helping people to improve their communication skills, is that I believe that poor communication isn't an issue of ability. I believe it's an issue of context. I do a lot of communication training, and I never teach anyone anything that they don't already know. And it's really important to recognize that we all know how to do it well, and we could all sit a test, and we could all write a perfect script for how to interact with a patient well. The issue is not our knowledge, it's our ability to do it in the moment. And I believe that the one of the strongest barriers to communicating with empathy and your ability to make a social connection with patients in the moment is your emotional response to the situation, your emotional response to the patient. And part of that is, and that's just human. It's human nature. It's human behavior. And we need to spend more time, instead of teaching people communication skills, we need to teach people emotion regulation skills. We need to teach people to identify their own emotional response to patients and recognize it and regulate it and respond to it so that they can overcome their own barriers to communicating with empathy.
Okay, very interesting. And I can see that your colleagues agree with that as well. And how about you, Kai?
Maybe not in order not to repeat too much what was already said, I can speak more from the perspective of a scientist, because I think to me in the past years, the one thing about the social dimension that I always notice is that patients have it very clear how much it matters, but it's really the healthcare professionals and the scientists that study pain that seem to lag behind in understanding of social factors in pain and pain communication in particular. So I think my key challenge still would be to increase visibility of social factors, develop better theoretical models that incorporate a lot of research that we already have in separate areas into a more common model that recognizes social factors, identify key mechanisms, social mechanisms that can be targeted in clinical treatment. And of course, those are all very broad goals, but I think that still has to be the target to better line up with patient needs in clinical practice as well, to have their social needs met in addition to their needs of pain reduction. So I think that would be my key challenge.
Okay. Super, thank you very much. And I would like to warn our attendees that if they want to ask a question to Kai, they have to do it quite fast, because unfortunately he has to leave in a bit less than 20 minutes. And actually we received a question for you, so it's perfect. Saying that you mentioned dementia patients in your session, and how could the aspect of dementia be better recognized and accounted for in pain treatment? And how about in situation where family is not part of their lives?
Yeah, it's a good question. I should say to that, I'm not a clinician myself, so I speak from a rather detached scientific view on that. But I think the first part of the question indeed is another argument why we need to broaden our idea of what pain treatment actually is. It should focus on much more than just assessing pain and reduction of pain. So for instance, dementia, a lot of people and probably a lot of clinicians would still underestimate the effect that dementia would have on pain treatment and pain communication in particular. So I think it is important to include all these kind of different information that you can get about a patient in pain treatment as well. And the second part is also what you just said about, and one source could be family, of course, but you specifically say family is not involved in their lives, but just to stay at that point for a moment, like include information from close other social relations of the patient as well, because they can provide a lot of context, which will be really important to better understand how someone communicates pain and lives with pain. If there is no such social support systems that you can include, I think then it becomes very challenging. Then it has to be multidisciplinary, because most likely someone with dementia has been in contact with other healthcare professionals independently of their pain needs. And then there needs to be better communication between healthcare professionals to get a more complete, holistic vision of who that patient actually is. That would be my answer, but probably someone with more clinical experience can add to that question as well.
Yes, so one of you had the case of a dementia patient that they can maybe share with no?
I don't have a case of a dementia patient in particular, but I like, there's quite an interesting, the concept of involving others. So whether that's family carers, where we can get that bigger picture. And I guess one of my questions to everyone is, what would be the challenges with that, and how can we practically put that into practice, because that in itself changes the whole dynamic, and but yeah, it's such a key part, isn't it? general question.
Yes, we're also here for that. So I don't know if the other panelists have something to respond to that. Otherwise, we receive a couple of questions. And so we have actually one for Ulrike, which is, what is your recommendation for patients with persistent low back pain?
Thanks, Katie, for this question, but this is the box of Pandora. Well, there are many prompts out there for several issues for chronic low back pain or for back pain, and I do not know what you want to measure. If you want to measure pain, there is a core outcome set recommendation by Chiarotto and his colleagues, and they recommend the NRS for measuring pain and low back pain. Then there are several other issues if you want to measure or assess, maybe it's better to say assess, physical function. You have so many different scales for assessing physical function and low back pain. I think the most scales deal with low back pain. So just to briefly mention the Rowland and Morris disability scale and the Oswestry disability scale. So this might help for the first step. For emotional aspects or social aspects, this is more general. There are no specific measures for back pain. So maybe the distress, anxiety, depression, anxiety, distress scale might help. The Hudson anxiety depression scale is not to be recommended. And of course, you can use also scales for assessing health-related quality of life. There are some back pain specific scales. I have no idea if they work, but general health-related quality of life scales would work too. But I would like to invite you to have a look at the articles of Chiarotto and his colleagues, because they have given a broad overview of psychometric properties of scales just for assessing aspects of low back pain.
Thank you. And actually, I have a question for Kai. So you indicated that like your challenge would be, the main challenge in your mind would be, our researchers, well, fundamental researchers tend to forget about the social aspect of pain assessment. So what would be maybe your suggestion to balance this out, and or to maybe push fundamental researcher to include this part into their own research?
It's twofold. I would say, on the one hand, I feel a lot of researchers already included, but are not aware of it. So a lot of researchers, they investigate things that, in my mind, are very social. Like, you have a whole research area that looks at dyads between parents and children, social learning, stigma, invalidation. Those are all very important social processes. If you look at them as a whole, they all have to do with pain communication. They all have to do with pain assessment. But I feel there's very little cross-pollination between them. Like, for instance, if you look at the stigma literature, they get a lot of inspiration from the social psychology literature, where there is a lot of stigma research out there, but it's just starting to really make an impact in the pain field. So I think the first step would be to, if you already study things that are important in regards to social processes in pain, to try to incorporate it into existing theories and push those theories and give them more visibility in the pain field. Explain why stigma theory, invalidation, these processes are actually important for pain. And join our EFIC, because if you join our EFIC, then you're basically part of this larger movement to be under this common goal of increasing the visibility of social factors. And secondly, if you do not already do it, then a lot of people don't do it. They don't want to go too far down social roads, because it is very challenging for experimental research in particular, because it's a lot harder to control. As soon as you bring two people to the lab, you have the dynamics, the interactions, and it's a lot more important for naturalistic, valid experiments, but it's a lot harder to control experimentally. But I would say, yeah, you have to pay that price in order to do more meaningful research for clinical practice, because clinical practice is always about an interaction between at least two people. So I think if you can include that in your research, at the very least, including outcome measures, which we also have too little of, to measure social contracts that you know are important, that's a start. And if you come up with great experimental manipulations of social processes that are clinically relevant, then that will definitely make an impact. I think the promise is that there's still a ton to do. And that might be true for most areas, but it's especially true for the interpersonal social areas. So I think that's a promise for if you're scientifically minded, curious, there's just a lot you can still do and borrow from other fields as well.
And I'm a bit curious about our more clinician panelists. Would you like to see like the fundamental research focus on certain area in particular, based on your experience, or what you think things are still missing in the field? I know it's quite particular because in psychology it's quite broad and it's difficult, but you might say, oh, I would like to see more research on this specific topic because it's missing. It can be even like for Claire, I'm thinking about some bias about maybe age, like having someone that is sick but he's quite young can be seen as more, well, you're young and you should be healthy. So maybe there's not a lot of data on this part of bias, for example.
I have a quick response from my field. I would like to have much more fundamental work. It's not really research, basically, but it's just having good constructs. Elaborated constructs, differentiating constructs, and some colleague of mine say clear out the mess. So the question is how much how much association is between threat, Kai, and catastrophizing maybe. So is this pain specific or is it not? It's just a natural feature of a person. So what I think we need much more clear constructs, not more questionnaires and not more research questions, just have an idea what we want to assess or want to investigate.
So maybe another field of research for you, Kai.
Yeah, I agree, though. I think that's the very basic. It's very messy. There's a lot of, like, take social support as an example, which there's a lot of research out. And if you ask 10 researchers what they mean by social support, they will come up with 20 different answers. And that might also be something that is very visible in social psychology as well, but the constructs are not very clearly defined. And that also leads then to having not a lot of measurements or a lot of different measurements where we're not sure exactly what they measure. So I think it is then very hard to make any strong claims about clinically important mechanisms that we should target, because we're not really sure. Yeah, we know that social context matters, we know that social mechanisms matter, but we don't really understand, I think, enough about how they impact pain and how they're impacted by pain. And that is one of the reasons.
Right. Thank you, Kai. So I think if you need to go, you are free to. And thank you.
Apologies, I have to attend to a painful procedure of my son, so it is. It stays within the domain. But thank you.
Yes, thank you for being there, and have a good afternoon. Bye. And otherwise, we received plenty of questions in between. So let's start with the question for Claire and Arvinder. Where can I find more information about communication and emotional regulation courses?
Do you want to go first, Harbinder, or would you like me to? You want me to? Yeah, I can't hear you, so I guess that's that. At the University of Sydney, we have online. They're live and interactive courses, but they're hosted online. So we do a lot of online international webinar-based, interactive, group-based communication training. If you just Google University of Sydney, or if you just look me up at the University of Sydney, at the Pain Management Research Institute, I do workshops on managing emotionally challenging patient encounters. And I look at the two parts of that, the difficulties identifying and responding to patient emotion and mitigating distress in patients, which is really important. and also mitigating distress in clinicians. So I run all my workshops online for global audiences, and they're all through the University of Sydney.
Yeah, that's really good. I guess the only thing I would want to probably add from my perspective is a lot of the training that I've delivered so far in terms of communication has been within sort of when we're developing behavioural change interventions and testing them within sort of clinical trials, and a part of that we develop the communication skills modules. But as you were talking, what I was thinking was actually this would be a great place to have that sort of training within, even within EFIC, you know, whether we can incorporate some of that because I can see nodding on the panel, because I think that would be a really good and easily accessible, because what we find sometimes is there's lots of things happening in various places, but pulling it together, I think just which is one of the great benefits of this, I think.
May I add? Because I totally agree with Harbinder that EFIC should take care of good webinars for this matter. And what I really would appreciate under the roof of EFIC is to have a cultural exchange, because communication is always influenced by cultural aspects. And I think we learn so much from each other, how French communicate and German communicate. I think the German can even more learn from communication styles of others. But I think this would much help to understand patients from other cultural backgrounds we have to treat in our daily routines as well. So, yeah.
And so, by the way, anyone can suggest to organize a webinar. And of course, if it's like a gap that you think is missing, we will be really happy to organize. And of course, depending if it's it can be part of the EFIC academic curriculum, it will be linked to the academy. If it's not, it will be linked to the other part of the webinars by EFIC. So feel free to send us an email and we will be happy to make it happen, really. And otherwise, so receive a question for Claire, actually. Is there a difference between male and female clinicians when it comes to bias in pain assessment and pain clinician interaction? For example, do female clinicians perceive female patients differently than their male colleagues?
That's a good question. So I can give you the experimental psychology answer, the social psychology answer, and I can give you the real world answer, and they're different. So the social psychology answer is that implicit biases are universal across genders, and that, you know, females also hold stereotypes about females just as men do. But it's what's really important to recognize in reality is that when we're faced with a person, there are many different stereotypes that we could apply to them. If you are sitting in front of a patient who is a female and from and Moroccan, for example, which stereotype are you applying? If the female Moroccan is a doctor herself and introduces herself, I'm a doctor and I work for the NHS, which stereotype are you applying? So it's really important to recognize that the stereotypes are activated, but the stereotype that's used really depends on the context. And the context is what determines which stereotype is most relevant for the judgment at hand. So, for example, if you have a clinician who is a female, and I've done research on this, both experimentally and in the real world, naturalistically, when I conducted experiments of patients' perspectives on the warmth and competence of male and female surgeons, I found strong gender effects, very strong. When I then did the same study in practice, in reality, naturalistically, there were no differences in people's perceptions of male and female surgeons, actual surgeons, because a patient, when they meet a male and female surgeon, they're not thinking there's a woman. They're thinking there's my surgeon who's going to cut me open, right? They're They're extremely motivated to see that person as a surgeon first. And so it's what is most relevant at the point in time that the judgment is made. So I do think that with this implicit bias research, there's a lot that experimental studies can tell us in terms of the impact that the stereotype can have on emotion and behavior. But in practice, what we have to recognize is that the context will determine the type of stereotype that's activated and the consequences therefore.
Very nice. So thank you. And we have a last question on the pipeline for Ulrike, which is, isn't the measure you want to use dependent upon the purpose of research? And it's a long question, sorry. If you want to investigate it in the context of treatment, then a time dimension is important. Or if you want to investigate it in the context of natural recovery, then the predictive validity may be important. And for this different purpose, different tools may be used. What do you think?
Yes, first of all, I'm happy to hear from you, Dimitri. We had the webinar last time together, so I miss you here in this round. So yeah, as always, it's complex. So for the first part of your comment, I agree. We need to be really clear what kind of assessment or measurement instrument we need for what target population, for what context, for what purpose. Yes, but I do not agree with the following sentence. And this is a little bit unfair because I'm here to express my vision and my point of view, and you're sitting there and have to keep it, what you think or would like to answer. But maybe we can continue this Budapest next year or this year. Yeah. So why I do not agree. I think in your comment, there are some different issues mixed, and I would like to be clear on that. The first thing is that we should be clear on are we interested in treatment outcome and endpoints, or are we interested in instruments predicting or helping us to find subgroups for better allocation to treatment interventions? And I think these both contexts of use need different instruments. I think we need different instruments for screening or subtyping patients, and we need different instruments for assessing outcome. What you propose makes or points of a problem we have. We have an effectiveness efficacy gap. So we have outcomes in clinical trials we cannot replicate in real world. So public health creates different results in clinical trials. So I mean, Claire, it's the same issue in my field of research. And when we use different instruments for that, then we will even burden or broaden the gap. So I think we should find instruments for both clinical trials and public health research. And still, we need to have different contexts because it's not only patient-reported outcome measures, we have patient-reported experience measures, we have clinician-reported measures, we have objective measures. I think this is something we need to be clear of. So this is my opinion. Yeah.
Super. Thank you very much. And otherwise, another question, lots of questions. I'm really happy to see that. Question for Harbinder. How can a well-balanced medication can be negotiated in practical terms? How can pain treatment option be better communicated with patients? For example, patients who refuse medicine in their treatment plan.
Thank you. Yeah, that's a really good question and one that is a challenge for many of us. So I've just completed a clinical trial where we've tested the effectiveness of a behavior change intervention, self-management educational program to help people taper off their opioids, and results should be hopefully out this year. And we've learned a lot from that trial, from talking to not only our participants, but people that were patients and public involvement in terms of helping us design the study and really understanding what the challenges are when we're speaking to patients and helping to negotiate that plan. So I guess I'm coming to this question with two aspects, both from the clinical research, but also from as a clinician as well. And I think one of the first things is to really understand why the patient, or where the patient is in their journey, and their understanding of what medication is and how it may be or not be helping them with their pain or sort of with the aspects of their health. I think a lot of the challenges now, especially with a lot of the research that's coming out around opioids in particular, is again that stigma related to taking opioids even in the first place. You know, why was I even prescribed them? And I think to be, as a clinician, it's to be aware of that in a consultation, because even if you approach the subject, your patients might already have that kind of barrier, or sort of like the defense barrier might be up, because they might be perceiving what's being said to them in a completely unhelpful way, and that's not their fault. It's just because of what they perceive as being understood by the whole conversation around taking opioids. So I think with anything, practical tips are to show the empathy as you're having that conversation, to show understanding, and to be able to give time to have that element of education during the consultation. So to help patients perhaps understand where and how medications can play a part in pain management, to explore with the patient the risks and the benefits, and to really tailor then and really help the patient believe and understand that it is being tailored. So it's not a sort of one formula fits all in negotiating that tapering plan. Because I think one of the learning points that we found from the study was that, you know, people, the participants or patients really felt like they were being listened to, and that helped them make the decision themselves about whether to taper or not, or what their medication plan should look like. So I think it's really important to approach the subject. I think it's important to be open about the subject and honest, you know, and I think as clinicians, you know, it is that, you know, evidence now is showing, we know that long-term effects of using strong opioids, for example, isn't always the best solution for people. But that's not saying that for some people, small amounts is okay. And I think this is the tricky part, the fine line. It's seeing the patient, understanding the biopsychosocial contextual factors for the patient, and really helping the patient with you to understand the risks and benefits, and then going through the negotiation of a tapering plan. It is tricky. I'm hoping this year to publish more around this area, and also, you know, to perhaps even again within EFIC, you know, this, I'm just thinking of all these ideas for particular webinars. You know, we could really home it in on certain topics, and that would be definitely one that we could explore.
And once again, feel free to email us with any ideas that you have here, and within the organization of this webinar, this webinar, to organize more webinars, or even suggest some session for the next congresses, or just a suggestion. And on my side, I had a question for Claire, actually, because you indicated that when you teach clinicians about communication, it's always something that they know, and you would like to mainly focus on how people react. But how can you train someone to regulate their emotion? Do you wish to see more workshop on this aspect in the clinical world? Does it already exist, by the way?
Yeah, there's a whole field of work on emotion regulation and emotion regulation strategies, and emotion identification, and responding to others' emotion in a way that helps them to downregulate their emotion, de-intensify their emotion. Mass is like a big evidence base, so we're really lucky that this is not a black box. There evidence-based strategies that we can use to help patients to downregulate their emotional state so that they're better able to engage with us in conversation and we're better able to build trust. And there are evidence-based strategies that we can use to recognize and respond to our own emotional state in the moment during consultations, and then also later on, like with self-care and mindfulness and things like that. But in the moment, there are basic things that we can do to help regulate our emotional state that can be done in a matter of seconds. So yeah, that I think it's really important for people to deal with their emotional state first, because the rest follows naturally. We communicate, we behave based on our emotional state. It's our emotions that drive our behavior. It's our emotions that drive our motivation. And if we can fix the emotional state, then the rest is so much easier.
And after all, we are only humans, so it's quite complicated to, I guess, put aside our own bias, to first to recognize them and to be ensured to be the best doctor for our patients. And then I think we have another question for you, Claire, probably a follow-up. You spoke about finding similarities as a tip for dealing with bias in your session. How easily are clinicians able to find similarities between themselves and patients? And where goes the line for over-emphasizing, for example, resonating too much with said similarities?
Yeah, that's a great question. There are really two questions in there. The first part of the question is how easy is it to find similarities with patients, and I would argue it's very easy when we take their social history, which everyone should be doing during any pain consultation. You take a social history, you find out what their family situation is, their living situation, what's their social support like, find out their life story. We're at the end of the day, we're all human. We all have things in common. We're all firstborns, or we all have experiences with, a lot of us have experiences that are very similar across cultural barriers. Like, this is the cross-cultural human experiences. So finding similarities is not difficult. All it requires is for you to express curiosity in someone's social life. And people are really interesting when you ask them about their hobbies, they are. And the second part of the question was, where's the line? And do we resonate too strongly with people if we see them as too similar? That's interesting, because I'm reading into this comment, but it suggests that the person who made the comment tries to prevent themselves from seeing similarities with patients in order to create some distance from patients, some depersonalization, which they feel, I'm reading into this, of course, which they might assume protects them from over empathizing. And unfortunately, that depersonalization process doesn't protect people from emotional resonance. What it does is it prevents people from addressing their emotional response to patient situation. Because they've depersonalized it, they're not necessarily able to identify their emotional response to the patient. Because we all have a brain with an amygdala, and we all have automatic responses to what people are telling us. Whether we want to empathize or not, we will. And so the answer is not to suppress empathy. It's not to suppress a feeling of connection and sadness and disappointment, but to recognize that you're feeling an emotional response to this person in this situation, to recognize the context of your emotional response, which might be, I've had a similar situation myself, I'm finding this really upsetting. And that process of acknowledgement helps you to process your emotional response to it, understand where your emotions are coming from, that it's from your life, not theirs, and help you to respond appropriately. But if you're depersonalizing, you miss all of that. The emotions are still there. And there's a large literature on unconscious emotions. You might not feel anger, but you can still have anger implicitly driving your cognition and behavior and the way that you interact with patients. So it's better to have anger, feel anger and feel disgust than to have suppressed anger and disgust, because you're much less able to control and manage your responses to those sorts of emotions.
Yes, Ulrike?
Yes, I would like to express some thoughts I have when I was listening to you, Claire, because I think you hit such an important issue, which you started with, Harbinder, with the treatment relationship between healthcare professionals and patients. And this is something I really observe, and I think this is so important to be clear about my own emotional regulation state. And what you said about patients, Claire, in the first place, I think we professionals need this too, urgently. And now we are psychologists right here, so we have a common understanding of relationship factors and how we can influence them. But I work in a multidisciplinary team with physicians and physiotherapists and nurses, and they have not this body of knowledge or practice. So this is always a problem when I have, or no, I do not have a problem with the patient. Maybe the physician has the problem with the patient, and then the physician approaches to me and says, solve it for me. I cannot, you're the professional. So the question is how we can spread our knowledge into such teams to enhance communication for those who have not been able to, study psychology, and also to save or rescue the psychologists overwhelming approaches from the team. So I think the emotion, being aware of the own emotional state and having some abilities to regulate my emotional state as a professional is so important.
Yes, Harbinder, I think you want to contribute.
Yeah, I think that's a really good question. And I think, it's not always easy because, time pressures and so on to get your whole team on board and, do all of the sort of the training as such. But I think having multidisciplinary team meetings is really important. Whether that's where you have cases where you can discuss, where you can then, bring in the different aspects and have that open communication, because that's where, as psychologists, we can really contribute and show and then work with the team.
Yes, we can show. I really agree. But what we cannot do is replace the missing practice by the others. And I've been working in multidisciplinary pain teams since 20 years, and we have an interdisciplinary pain project with so many teams, and all what I'm watching, they have the team meeting. They share their information about, factors for diagnostic and treatment, and they have some ideas what might be a good thing to help the patient. But what they never do is talking about the process. How do I feel when you talk to the patients? How do I feel when you express your model of pain to the patient? They do not express the feelings between each other. So, you have role misunderstandings, you have personal issues in such close relationships when you work together in an integrated team approach. So they never do that, and there's no awareness that this is necessary. And that's why I was so triggered by you, Claire, because this inspired me. We still think how we can make people in those teams aware that this is an issue to be worked on together. It just that doesn't happen that you feel fine with the team. It's work.
And I'm wondering from because so you might not know, but actually I have a PhD in neuroscience. I'm a neuroscientist originally, and I've dealt in the past with mental health issues where I've seen a psychologist, and I feel like lots of people have some trouble being vulnerable and talking about their own emotion, mostly regarding work. Like they try to separate at least, okay, work is work, personal life is personal life, even though it's scripted out. Of course, you will have some people snapping at each other because they have some personal issues or even professional issues, and they have to put it out somewhere. But it's really difficult to have people talking about their own emotions in a professional context. At least it's what I've I felt. And I guess apparently you agree with that. And also because I worked with doctors and scientists, and usually it's difficult to, mostly for doctors, apparently for clinicians, to link together the emotion with their practices. And I feel like, and apparently you feel like also there's a need to be a bit more, to have a bit more awareness of that is necessary, and maybe having even try to also alleviate it, the work of the psychologists, because you have a mental level and emotional level for the whole team regarding their patients, while they should be also taking some part of this work, because of course they work sometimes more closely with a patient than you. And that's why when you say, Ulrike, having this, the doctors coming, oh, my patient have this issue, fix it for me. You don't have the whole picture. You don't have the background. You are not working maybe every day with them, so it's difficult to do that. So you need, I guess, to have a bit more, yes, involvement or training, psychological training within maybe the medical field, because of course, I think about a generalist, they might be trained about, you know, from the whole part of the body, perfectly fine, but they should also take in consideration the mind of the patient. At least is what I take from your discussion. Tell me if I'm wrong.
No, I think that's a really good summary, actually, and you've touched on sort of core curriculums, you know, going back to actual education and what's being taught at that level, and that's even just one section of it, because once you've graduated and done all of that, it's then putting it into practice and making sure it continues, and I think that's another sort of challenge.
So maybe there is a need to see, as you say, with the education first, because of course, once the doctor is in practice, they are already quite well trained into their specific process that they learn. And of course, I'm quite sure it's different between countries on how they are how they are trained. And but yeah, it's maybe something that can be discussed further and to find solution, because of course, we cannot expect physician to be able to do everything by themselves, perfectly fine, but at least having some sort of training. And I'm also thinking about gynecology, where I don't know for in other countries, but in France, sometimes in their practice, it's in their training, it's really passed upon really quickly with not a lot of background, and sometimes it brings some issues in the long term. And maybe having a bit more training into the psychology of the patient, and also being themselves aware of what they feel when they practice, when they how they heal their patient, also to, you know, to facilitate your work, their work, and also the patient to have a better communication in general, because of course your role arrives sometimes a bit further once maybe I'm thinking about a cancer patient. Maybe the psychologist is stepping up at quite late into the process, and maybe I guess sometimes you can feel that you're a bit late in the game, and a lot of things have been missing, and the mental health has been a bit forgotten, maybe at some point. Sorry, I felt like I talked a bit too much, and we are actually quite close to the end of the webinars. We still have some time, don't worry. And actually, Katie has another question for you. And thank you so much for highlighting the need for emotional regulation and training. Completely agree with points raised. As physio, we don't get the training of these issues and think we could benefit. Are there any suggestions on how to highlight the need for this within the MDT? Really good question. So,
so Katie, it sounds like you're a physio. I think probably just bringing it up at the next team meeting, to say that you were at this webinar, and some interesting discussion came up about communication skills really hinging on the emotional state of the clinician. Most clinicians have a bit of self-awareness and can recognize that they, and I say this because I teach clinicians, and hundreds of clinicians have come through the programs that we run, and most of them will admit that, yeah, there are some patients that you just want to get out of the room, like you just want to get out quickly. Some are hard to listen to. Sometimes it's easy to ask, be curious about someone's life and what they do, what they're interested in, and what their goals are. And sometimes it's really hard. Why is it easy for some patients and hard for others? Well, partly there's the implicit biases, you know, in there, but it's that emotional response and that motivation to get out of the room or to stay, to approach or to avoid. And most people are aware at some level of the differences in their response to different patients and aware of their emotional response to people. And I think most people, once you talk about it, are aware of the impact of their feelings towards patients on their behavior towards patients. So I think it's just worth bringing up and chatting about it. And most people find once they start talking about it, they're like, oh, wow, we've never learned how to do this. Why have we never learned how to do this? And there's like a lot of excitement about it. So yeah, it's rewarding and worthwhile. I think it's worthwhile conversation.
And maybe, Katie, you could take one of your colleagues and just watch the videos from Claire. And then have a fine discussion with popcorn and some sweet beverages. I think this would be a good start to take somebody on board.
Sounds like a nice after work evening, actually. So no, I'm really sorry. It's kind of the end of the webinar, and maybe we could have like a last word from all of you for the volunteers. Okay, we'll get the popcorn ready. Thank you, Katie, for this wonderful question. So we can make a last round on if you have some last word for attendees. Arvinder?
Yeah, I just want to thank everyone for joining today and for some really, good questions. I think this is a field that's continuously evolving, and, it's great to have these collaborations. And, we've highlighted today some gaps even within EFIC that we could probably, put some further thought in terms of educational webinars. But yes, thank you to everyone.
And Ulrike?
Thanks, Lorianne, for inviting me to this really interesting session. So I get in touch with Harbinder and Claire. It was really interesting and inspiring, but also all the questions had been inspiring to me, and I will take much of those back to my team as a take-home message. Thank you.
And how about you, Claire?
Yeah, thanks. It's always really heartening when people are interested in communication with patients, and it gives me hope, because you need to, again, emotion drives behavior, and if people have curiosity and interest and are intrinsically motivated to learn more and understand it better, then I think we've got hope for behavior change. It's good.
And yes, and thank you all for being there to discuss. And it's also one of the goals of these webinars to bring people together to discuss and maybe finding I don't want to say issues, but mostly room for improvement, let's say, and see what we can do all together and also within EFIC. And thank you all for our attendees for the wonderful question. And of course, this webinar was recorded, and you will be able to find it quite fast on the academic platform. So thank you all for being there, and see you soon at EFIC.
Thanks, Lorianne.
Bye.
Thanks, Lorianne.
Bye. Bye.